Fungal diagnosis can be a little bit easier than diagnosing other types of infection because fungi are so different from bacteria and from viral infections. However, the treatment can definitely be complicated. When we're trying to recognize fungal infections, the microbiology, microscopy, staining, blah, 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 is often the easiest, especially microscopy, because they're almost always extracellular, so they don't go inside of host cells often. They're eukaryotes. They're much bigger than bacteria, obviously much bigger than viruses. So they're a lot easier to see under microscopy. They have a cell wall that is different from the cell wall of bacteria. So you could always look for cell wall components because, again, they're different. Culture, especially for some of the opportunistic fungi, is not complicated. They actually will grow pretty well. They usually grow a little bit more slowly than some of the bacteria. And if you're specifically trying to grow fungi, you will often have to adjust your growth media a little bit, but not terribly complicated. When we're talking about some of the endemic fungi or the systemic fungi, the ones that can make healthy individuals sick, we sometimes don't want to do culture because they are biosafety level 3, or they can be biosafety level 3, which makes them more difficult to work with. Of course, you will mount an immune response, so you can do things like look for antibodies or antigen. Histopathology, as a modification of microscopy, basically you take a patient biopsy and do particular staining, is often really useful for diagnosing fungal infections. As with any infection, if you're trying to diagnose a fungal infection, you want to be aseptic when you collect your samples. There are a number of different fungi that are associated with the human body. It's part of our mycobiome. So instead of microbiome, we have fungal organisms that live with us on our skin, especially in the reproductive tract, sometimes found in the respiratory tract, that are commensals. They're just there. So you have to be really careful that you're not grabbing a fungus that's not causing the infection. You want to make sure you grab the infection-causing agent. You transport them, as always, sterile, leak-proof, with the clinical information. If a patient has a skin lesion or you've taken a sample of the GI tract, you can do a biopsy of that. Oral and vaginal infections are best diagnosed by clinical presentation and direct microscopic examination. So for direct microscopic examination, again, pretty easy. You can see yeast, you can see hyphae. Sometimes the morphology of the fungus is so unique that you can actually identify it to group or even species. Culture can take a little bit longer depending on the organism. So oftentimes, again, microscopy might be one of the easiest things to do. These are some examples of what fungi can look like under the microscope. You see like the yeast forms. Here you can see some of the hyphae that have formed. In this one, you also see kind of a combination of yeast and hyphae. Again, once you're trained in the microscopy, those of you who are going to be on the clinical laboratory science side versus like the medical working with the patient side, you'll be trained in how to recognize these organisms under the microscope, and that will be really helpful for you. Again, culture can also be useful to diagnose fungal agents. Usually you'll use a selective and a non-selective medium. Sometimes you do require blood in the growth media, like a blood agar plate. Oftentimes, if you're trying to culture fungi compared to culturing bacteria, you increase the sugar concentration and you decrease the pH of the media, and that can usually exclude bacteria and select more for fungi. As you might imagine, there should be, if you ever culture the blood, there should be no fungus in the blood, no bacteria in the blood either. So if you find a fungus in the blood, that's a problem. Most fungi actually will grow best outside of the body at 25 or 30 degrees, between 25 and 30 degrees. So it's important that you think about what potential infection a patient might have and research what would be the best culture conditions for that organism. And again, for most of these fungi, you're going to be able to identify them in culture within 5 days to 2 weeks. And that, I know that sounds like a long time. With some of these fungi, they are pretty slow growing. So it's okay that it takes a little bit longer. But if a patient is in really serious condition, you may want to do a more rapid type of test. So you could do antibody or antigen detection. Depending on the fungal infection, some antibody tests are not as sensitive. And think about it, right? Fungi are eukaryotes. So the problem is there's going to be a lot of features of a fungus that are in common with us. So there may not be as many unique antigens for us to mount an immune response to. There are some. The other thing to think about is, again, we sort of coexist commensally. We coexist commensally with a lot of fungal organisms. So our immune system has seen a lot of fungi. And again, finding the unique antigen of the pathogen might be tricky. You can look for cell wall antigens or metabolites that are produced by a potential pathogen. Of course, PCR to detect fungal DNA is something that is in the works. The technology shows a lot of promise. It hasn't been fully developed yet for all fungal infections, but again, it is getting better. When we talk about treatment of fungal organisms, I mentioned before that treatment can be complicated because fungi are eukaryotes, just like we are. On one of the previous exams, there was a question of, why are viral infections harder to treat than bacterial infections? And a number of people put, well, because there are no antibiotics for viral infections. And that is not accurate. Well, it's technically accurate, but it's not why. The question wasn't, well, because antibiotics don't work against viruses. It was, why don't antibiotics work against viruses? So the reason that viral infections are so hard to treat is because viruses take over the host cell. So oftentimes, in order to get rid of the virus, you're actually getting rid of the host cell, or you're negatively affecting the host cell. The only time we have really good antivirals is when we have a really good target in the virus that is unique, like a different type of polymerase, like reverse transcriptase or neuraminidase or something like that, that is different in the virus. With fungi, you're kind of looking at a similar situation where the fungus looks a lot like our cells. So if you stop a fungal cell, are you also stopping a host cell? So what we have to think about are what are the differences between fungi and humans and how can we exploit those differences for treatment? So we have these different terms that we've seen before: antibacterial spectrum, we have antifungal spectrum, a fungistatic drug, a fungicidal drug, antifungal combinations that are either synergistic or antagonistic, and efflux pumps, so mechanisms by which fungi can become resistant to antifungals. So it is critically important. I can't emphasize this enough. It is critically important that you understand that bacteria and viruses and fungi, and when we talk about parasites, those are all different types of organisms, and the treatment of them has to be different because of the different type of organism they are. And I know you might be going, well, that sounds really basic. Obviously, fungi are different from people, and fungi are different from bacteria, and fungi are different from viruses. But sometimes reading your exam questions, I'm not quite sure that point has been driven home. So I'm really trying to drive that point home right now. Viruses are hard to treat because they take over host cells. So to kill a virus, you're killing a host cell. Fungi, and eventually when we talk about parasites, are hard to treat because they look a lot like a host cell. So you really have to learn how to exploit those differences. The antifungal agents that we do have on the market do exploit a lot of the differences between fungi and host cells, fungi and human cells. One of the major differences between a fungus and a host cell is the fact that fungi have a cell wall. It's made of glucan and chitin. So there are inhibitors that inhibit glucan and chitin biosynthesis. This cell wall is different from a bacterial cell wall. So bacterial cell wall inhibitors that inhibit peptidoglycan biosynthesis or something like that, if they interfere with peptidoglycan, they're not going to interfere with fungi because fungi don't have peptidoglycan. If they interfere with fungal biosynthesis, they're not going to work against bacteria. So there's some differences there. In the cell membrane of fungi, they have a sterol called ergosterol. We have cholesterol in our cell membranes. So we can either inhibit ergosterol biosynthesis or directly bind ergosterol and cause membrane damage. The problem here is that we have similar enzymes to make cholesterol. So you can have some toxicity to host cells by interfering with ergosterol biosynthesis. And cholesterol looks a lot like ergosterol. So if a drug binds to ergosterol, it can also sometimes bind cholesterol and cause host cell damage. So we can get some toxicity with these drugs here. We can inhibit mitosis. There are some subtle differences in the way that we do mitosis. There are some subtle differences in the way that we synthesize our nucleic acids, and there are some subtle differences in the way that we synthesize proteins. Again, I said there are subtle differences. There are a lot of similarities as well. Sometimes these drugs, especially like the polyenes and then inhibiting biomolecule synthesis, sometimes these drugs will preferentially bind the fungal target. Most of the time, they preferentially will bind the fungal target, but then sometimes they're just like, I'm also going to bind the host target. So with antifungal therapy, there can be a lot of toxicity. Okay, so Amphotericin B is one of these drugs that directly binds to ergosterol, and it causes pore formation in the fungal membrane, and that causes the contents to leak out, and the cells will die. Well, they can also bind to cholesterol. It's a little less strong, but it can still happen. And this is fungicidal against most fungi. So you have holes in your membrane, you're probably going to die. The azoles and allylamines inhibit ergosterol biosynthesis. That disrupts membrane formation. We have very similar enzymes. In fact, if you've ever heard of statins, the drug called statins, they inhibit this enzyme right here. We have that in our cells too. So we have a very similar pathway, so you can have some sort of like cross-reactivity, but not as much. These generally have less toxicity than like amphotericin B. So the majority of antifungal agents that are available are usually azoles, like fluconazole, something like that, or allylamines, because they are more specific for the fungal enzyme than the host enzyme. We do have drugs that also inhibit cell wall formation. There are fewer of them. We have more drugs that inhibit ergosterol biosynthesis. Of course, again, there are some drugs that interfere with DNA, RNA, and protein synthesis, and then, of course, mitosis as well. What we are seeing a lot in treating fungal infections is combination therapy. So mixing something like amphotericin plus a DNA inhibitor, amphotericin and azoles, amphotericin and fluconazole. And it tells you, you know, there's been good success, maybe there's no benefit seen, minimal human data, etc. So the reason that we like to do combination therapy is because we are also seeing now a lot of antifungal resistance. So here are listed a number of different fungi that have resistance to various drugs. So amphotericin B, which attacks the cell wall, flucytosine, which inhibits like the DNA synthesis, 2 of the azoles, and echinocandins. So antifungal resistance, just like antibacterial resistance, is becoming more and more common, and of course is very dangerous for our patients. So fungal treatment is also complicated because fungi tend to grow more slowly, and so therapy needs to be longer than antibiotic therapy for bacterial infections. And patient compliance, if you're telling a patient, hey, you have to take this drug for like 6 months to clear this fungal infection, patient compliance is a big issue. So those of you who are going to be working on the clinical lab side of this, you're interested in CLS, you will likely be doing a lot of fungal susceptibility tests as well, so that you can inform the physician of the appropriate antifungals to prescribe to help treat that patient's infection.